history, epidemiology, pathogenesis. We'll spend more time on clinical studies of various treatment strategies because this is real to us now. We have to make decisions every day. And hopefully we'll have enough time to cover the key things that are on your minds. So let's start off with a little bit of history. This is the title page from the seminal article that appeared in the Lancet in 1967, in which these clinicians primarily described the syndrome of acute respiratory distress in adults, 1967. They had a dozen patients, most of whom with sepsis, some with pneumonia. They all had dyspnea, tachypnea, cyanosis, or hypoxemia. Their radiographs showed opacifications, infiltrates in both lungs, and they had good reason to think that this was a non-cardiogenic syndrome. So why in 1967 does this syndrome get described? The diseases that cause it, pancreatitis, pneumonia, non-pulmonary sepsis, severe trauma, these diseases have been around for a long time. But in 1967, patients had just been put on ventilators. Patients with acute respiratory failure with pneumonia and severe sepsis, they were for the first time being put on mechanical ventilators in the 1950s and 60s. So now some of them had a chance to survive, and the syndrome of acute respiratory distress was apparent. Also, the United States was in a war in Vietnam, and for the first time in the history of warfare, soldiers severely injured on the battlefield were evacuated by helicopters to field hospitals, resuscitated, intubated, and given a chance to survive. And many of them had the syndrome of acute respiratory distress. They called it Da Nang lung or shock lung. So that's why I think the syndrome presents in this publication in 1967. So how do you define ARDS now? Well, here's a publication from a consensus committee in 2012 that said that this should be a presentation acute in onset, less than 7 days. Hypoxemia defined as a ratio of arterial PO2 divided by FiO2 less than or equal to 300. Bilateral opacifications, not primarily hydrostatic. And if on a ventilator, the end expiratory pressure should be at least 5. They also suggested that we can categorize severity according to the P to F ratio, as shown in the first column. Mild hypoxemia with a ratio of 201 to 300, severe if the ratio is less than 100. And these ranges of severity correlate with mortality. Now, it correlates roughly. P to F ratio on the first day, these are all on the first day of presentation. They predict mortality, but many patients with mild hypoxemia will die, 27%, and many patients, 55% with severe hypoxemia, will survive. So keep in mind that this is a predictor, but it's not a very strong predictor. More recently, in fact, in this year, Mathé and colleagues with a large consensus committee said, let's lighten up on some of these criteria because many patients in resource-limited environments have the syndrome, but they can't go on ventilators because ventilators aren't necessarily available. So let's allow patients who are on high-flow nasal cannula at 30 liters per minute, or if they don't have an arterial PO2, let's allow a pulse oximetry hemoglobin saturation divided by FiO2 less than 315. Let's allow the use of ultrasound to identify opacifications in the lung, not necessarily a chest X-ray. And PEEP should not be required. Now, again, I think these ideas allow some patients in resource-limited environments to enter clinical trials and to be recognized as having ARDS, but they also will lead to some lack of specificity of the criteria. Some patients, for example, will be hypoxemic because of atelectasis. but nonetheless, we have to balance different imperatives. So here's a busy slide from Mathey and Ware, published actually 24 years ago in the New England, that a nice representation of numerous factors that contribute to the pathogenesis of ARDS. Focus on the left first. This is a normal alveolus. There's a type 2 pneumocyte on the left, an alveolar macrophage in the center. These macrophages normally reside in the alveolus. And there's a layer of surfactant generated by that type 2 pneumocyte. On the right is a severely inflamed alveolus filled with proteinaceous fluid. In the center is a macrophage that is generating leukotrienes and proteases. These leukotrienes, these leukotrienes attract other neutrophils into the environment. The macrophage is releasing IL-6 and IL-10, which further contributes to the inflammation along with tumor necrosis factor. Here we have neutrophils diapedicing across the endothelial barrier into the interstitium and then into the alveolus. So a very nice representation of numerous factors. Let's mention the type 2 pneumocyte gets injured. It no longer can generate surfactant. We have increased surface tension here, and that contributes to atelectasis. So how common is ARDS? We don't have a lot of data from many countries, but this study we think is the best, offers the best estimation of the incidence. It comes from an area in the northwest of the United States, an area called King County, where a nice large city, Seattle, is located. For one whole year, they identified every patient in King County that met the criteria for ARDS. And then they made a number of assumptions about how representative King County was of the rest of the United States. And they then used these estimations to calculate that there were 191,000 patients per year in the United States, of which 74,000 died, 39%. And it resulted in 3.6 million hospital days. So with this information, we realized that this is more of a healthcare problem than had previously been recognized. There were more patients dying from ARDS than were dying from breast cancer. And nowadays, many more patients die from ARDS than die from AIDS, HIV. Margaret Herridge, her life's work has been to demonstrate that patients who survive from ARDS, they're lucky to survive, but they suffer with sequelae. So she tracked down many patients who survived from ARDS in Toronto, Canada, and questioned them about how they were feeling, what symptoms did they have, and she assessed their pulmonary function. Pulmonary function does pretty well. Here we see forced vital capacity, percent of predicted. At 1 year, the FVC was 85% of predicted. The total lung capacity, shown in the middle row, was 95% of predicted. Carbon monoxide diffusing capacity, 72%. That's mildly reduced, but it's more reduced than these other estimations of lung function. But with 72% of your diffusing capacity, that's enough for most people to do what they want to do with exercise and physical activity. So lung function fares pretty well. What Margaret went on to show is that many patients with ARDS suffer from other sequelae, specifically neuropsychiatric sequelae. They're depressed. Some of them have post-traumatic stress disorder a year after they survive. They have sleep disorders. Their interpersonal relationships have suffered. So, and these problems persist in some patients for more than a year. So it's a serious healthcare burden. First, many patients die, and among those who survive, they suffer with neurocognitive and neuromuscular sequelae. Many medications have been trialed trying to improve clinical outcomes from ARDS. but there's been very little success with these trials. Here's a partial list of medications that were tried because they were thought to be useful. Many phase 1 and phase 2 trials were promising. Surfactant, shown in the left column, third row. Many clinical trials showed that if you give surfactant to a patient with ARDS, that arterial oxygenation improves quickly. But the clinical trials did not demonstrate improvements in clinical outcome. We'll focus on surfactant here because it's a particularly compelling story. Here's one of 2 publications in the New England Journal in 2004 from Roger Sprague and colleagues. They're in Southern California. Roger's clinical research career was focused on demonstrating improvements in clinical outcomes with the use of surfactant. Patients in this study were randomized to receive surfactant or placebo intratracheally, given directly down the trachea. Here we see the arterial PO2 divided by FiO2 ratio on the vertical axis plotted against hours on the horizontal axis. And as you can see, within an hour or two, arterial oxygenation improves because surfactant gets into those injured alveoli, improves surface tension, the alveoli that previously had been atelectatic and open. But the primary outcome variable in these trials was ventilator-free days, shown on the horizontal axis. Ventilator-free days is the number of days a patient is alive and off ventilation, counted backwards from 28 days. So if a patient gets off a ventilator at, say, day 20 and stays off the ventilator, he gets 8 ventilator-free days. More ventilator-free days is good, but it made no difference. Each of these pairs of bars are essentially equivalent. So the surfactant did not improve clinical outcomes. It improved arterial oxygenation, it improves the physiology, but did not improve the outcome. Why not? Well, maybe the surfactant preparation wasn't as good as they thought. In fact, surfactant is a complicated substance, phosphatidylcholine, various lipids, surfactant proteins, and so on. And maybe they had the wrong formulation. But this idea has been put on the back shelf. We don't use surfactant now in patients with ARDS, and with good reason. First, the clinical evidence supporting its use is not there. And second, it is very expensive. If we dose a human of 70 kilograms with the same milligrams per kilogram as the neonatologists do, it costs in my hospital about $44,000. So we don't do it. Now, what about steroids? I think steroids make a lot of sense. It's a naturally occurring substance, cortisol. It moves into the cell and moves into the nucleus with a chaperone protein, turns on the regeneration genes, turns off the inflammatory genes. This ought to work. Back in 1987, Gordon Bernard, he was at Vanderbilt. He led a randomized clinical trial where they enrolled 99 patients. They gave a very high dose of methylprednisolone, 30 milligrams per kilogram every 6 hours for 4 doses. So that's 8 grams of methylpred given in 1 day. Another group received placebo. They found no effect of this mega dose of corticosteroids for ARDS. Here you see surviving percent on the vertical axis plotted against days from entry in the study on the horizontal axis. No significant difference. They concluded that in patients with ARDS, high-dose methylprednisolone does not affect outcomes. The idea of giving corticosteroids died for a number of years. But then another idea occurred to some investigators that we should resurrect the idea of giving steroids, but let's wait several days before giving the steroids. Let's wait until the so-called late phase of ARDS. Here we see the results of 4 uncontrolled case series reports in various journals between 1985 and 1995. These are small, uncontrolled case series reports, but they all had ARDS for at least a week before they received steroids. And as you can see here, at the bottom of this column on the right that a high percentage of these patients survived. So they were sick on a ventilator for at least a week, and most of them survived. What's the rationale for giving steroids in the late phase? Well, let's wait for antibiotics to work, kill off a bunch of bacteria, wait for the immune function to control infections. And also in the late phase, the inflammation is transforming from fibroproliferation to chronic inflammation. And fibroproliferation and chronic inflammation is more steroid responsive. So wait for the antibiotics and immune function to work, and then give the steroids to snuff out the chronic inflammation. Umberto Meduri is the strongest proponent of giving steroids in ARDS, and he published a study in 1998 in our Journal of the American Medical Association, the JAMA. He waited 7 days before randomizing patients. He gave methylprednisolone to 16 patients, 2 milligrams per kilogram loading dose, then 2 milligrams per kilogram per day for 14 days, and then he tapered the steroids until day 32. Crossovers in this clinical trial were allowed. The primary outcome was the lung injury score, a reduction by 1 at 10 days. The lung injury score is a composite outcome variable that consists of how much PEEP is a patient on, how many quadrants are affected by opacifications on the chest X-ray, arterial oxygenation, and so on. He showed us this survival curve. Survival on the vertical axis, days after randomization on the right. And this appeared to be very promising. This was a small clinical trial conducted primarily in one hospital. When the data are analyzed according to the intention to treat, which it should be, it appears that the recipients of methylprednisolone had a survival benefit, 12% mortality before hospital discharge compared to 62%. But some patients crossed over. And when we analyze the groups of patients according to the treatment they actually received, the survival benefit diminishes and is no longer statistically significant. So it's a single study, and there were a lot of skeptics about what it meant. The ARDS network, that was a multi-center consortium that worked on the clinical problem of ARDS for about 15 years, starting in 1994. And they conducted a clinical trial called Late Steroid Rescue Study. And we wanted to use the same recipe that Meduri and colleagues used to see if it really worked as well as they thought. So this was a prospective, multi-center, randomized, double-blind, placebo-controlled clinical trial. We used the same recipe that Meduri used, except that if a patient got off a ventilator, then we tapered the steroids quickly over 4 days. That was the only difference in our recipe for the use of steroids. We did not find a difference in mortality between the study groups. As you can see here, the mortality rates are virtually the same, about 28 or 29%. Not a very high mortality. And one of the lessons we learned here is that if you're on a ventilator for a week, you've already survived this severe sepsis, or you've survived severe trauma. Now we just have to be patient and wait for the inflammation to resolve with whatever we're doing, antibiotics and so on. So the conclusions of this study called Late Steroid Rescue Study from the ARDS Network is that steroids are not recommended for severe persistent ARDS, and that conclusion is based on 60-day mortality. But there's some other interesting data here in the same study. Patients who received methylprednisolone had more ventilator-free days to day 28. Again, ventilator-free days are the number of days a patient is alive and off a ventilator, counted backwards from day 28. More ventilator-free days is good. As you can see here, there's an improvement in ventilator-free days of more than 4 days in patients who got steroids. Nothing wrong with that. All right, mortality wasn't any different, but patients got off ventilators more quickly. Likewise, intensive care unit free days were significantly greater in patients who got the steroids. More recently, we have some very useful data that pertain to the question of steroids. So here is the result of one of the recovery trials, recovery being a UK, United Kingdom-based consortium of hospitals that conducted various clinical trials in patients with COVID-19, and many of them had ARDS. Patients hospitalized with COVID-19, an open label randomized trial, over 6,000 patients in this trial, 300 and 700 patients were on ventilators in patients who got steroid or not, and the dose, 6 milligrams per kilogram for up to 30 days. Now, compared to the doses that Umberto Meduri used and ARDS Network used, this is a low dose. It's equivalent to about 30 milligrams per day of methylpred. So a low dose, surprisingly low dose. Patients, all patients considered, the usual care group had a worse mortality curve, as you see here on the left. And among patients on a ventilator, the difference in the survival experience was significantly greater. Actually, it was significantly greater, both in those, all patients as a whole, but even more so in patients on a ventilator. So based on this result, we do use methylpred, or I'm sorry, dexamethasone at a low dose in patients with COVID-19. Another study published in 2023, just last year, used a higher dose of steroids with COVID-19 who are hypoxic but not requiring ventilator support. They used dexamethasone, a higher dose, 20 milligrams per day for 5 days, then tapering, versus dexamethasone, 6 milligrams per day for just 10 days or to discharge. The patients who received the higher dose of steroids did poorly relative to those who received the low dose of steroids. So many studies, I'm only showing you a few of them, many studies attempted to show benefit of steroids. And only the study that used this low dose of steroids shows benefit. Why is that? Well, every time we use a medication to treat something, whether it be a tablet of aspirin to prevent a heart attack, or steroids for ARDS, there's a potential benefit and there's a potential harm. And if you give too much, maybe the potential harms outweigh the benefits. Give a lower dose, get the benefit, and maybe we'll get better clinical outcomes. So among the various medications that have been used, I think the evidence, and especially the more recent evidence, suggests that steroids can confer benefit. Many other medications fail to demonstrate the benefit. On the other hand, survival from ARDS is improving. We have longitudinal data from many studies that strongly support that statement. Mortality is improving, but the improvements are occurring primarily, we think, because of improvements in processes of care. Ventilator management, which we'll get into soon, sedation management, prevention of catheter-related bloodstream infections, fluid management, prophylaxis against deep venous thrombosis, and gastrointestinal bleeding. Here's several processes of care that we've worked on in general in critically ill patients, and these have made a substantial difference in the clinical outcomes of patients with ARDS. The Kress and colleagues published this report in the New England Journal in 2000, 24 years ago, where once a day they stopped sedative medications in critically ill patients on ventilators. And when patients became aroused, they then resumed the medications at half the previous dose, and they reported improved time on ventilators and improved mortality. And since then, we've greatly reduced our use of sedative medications. In my intensive care unit, when I attend, after 1 or 2 days of mechanical ventilation, after we're finished sticking needles, doing various painful procedures and so on, with the sepsis waning and the causes of delirium not so great, we say, let's try to get off the drugs altogether. And we find that in approximately half of our patients, they can be awake on a ventilator with no sedatives, and then we can begin physical therapy. So lightening up on sedation, we think, has made a big difference. Fluid management has made a big difference in ARDS patients. These are the cumulative fluid accumulations in 2 patients randomized to receive either a liberal fluid strategy or a conservative fluid strategy in patients with ARDS over 7 days. The liberal strategy, called liberal, but it actually resembled usual care. These patients accumulated 7 liters of fluid over 7 days. In contrast, patients in the conservative fluid strategy over 7 days accumulated 0 liters of fluid. And this was associated with some nice improvements in clinical outcomes. A 3% trend towards improved mortality in the conservative group, and a significant reduction in time on ventilator, improvement in ventilator-free days in the patients who received the conservative fluid strategy. So conservative fluid strategy is part of our armamentarium of processes of care. Prone positioning. I'm sorry, these are data from the these are data from the conservative and liberal fluid strategies. Mortality, I mentioned earlier, a difference of 3%, and ventilator-free days, a difference of 2.5 ventilator-free days. Now, prone positioning, several studies attempted to demonstrate improved clinical outcomes from proning, but they were probably underpowered. Only when we did a large randomized clinical trial in patients with ARDS did we begin to see the true benefit. How does it work? Well, these 2 CAT scans give us a good feeling for how it might work. Notice in the supine position, the ventral part of the lung is narrow. There isn't a lot of lung tissue here. And because of the hydrostatic gradient and pleural pressure surrounding the lungs, there's little or no atelectasis here. But here where the pleural pressure is higher, and here where the pleural pressure is higher, there's a lot of atelectasis. If we turn this patient prone, we get more atelectasis here in the prone position, but we get less atelectasis here than was in the supine position. So what we gain here is greater than what we lose here, and the net result is improved arterial oxygenation. More aeration, less shunt, improved arterial oxygenation. And as you may know, when Guerin and colleagues conducted the large clinical trial of proning versus supine positioning, there was a very substantial improvement in clinical outcomes. I like to show this slide to remind myself that proning is not as easy as turning a chicken on a spit. It takes 4 or 5 people to go into a patient's room at the same time. These 4 or 5 people are busy in other rooms, but it takes a lot of teamwork and coordination. After you do it a few times in your intensive care unit, your team gets used to it. They accept it as part of usual care, and it becomes part of our routine. But it's not easy. You need a protocol to do this. The protocol specifies the job descriptions of everybody in the room. They usually assign me a rectal tube because that's the only tube they trust me with. But a respiratory therapist handles the endotracheal tube, nurses handle the chest tubes, and so on. With a protocol, and if you email me, I'll send you our protocol. With the protocol, everybody knows what they're supposed to do, and it becomes routine. Let's turn to this issue of mechanical ventilation. Right. Here, I like to use this colorful representation of lung volume versus time in a patient on a ventilator. In the low part of this drawing, the lung volume dips down into the pink and red zone, where ventilator-induced lung injury can occur because of atelectasis at these low lung volumes, and then reopening with each breath. In the high part of this lung volume representation, the lungs become overdistended. They go into this pink and red zone where lung injury from overdistension may occur. So there's two causes of ventilator-induced lung injury. You can see those two causes represented here on this CAT scan, right? High volume, high pressure injury, and low volume, low pressure injury. So we need to ventilate in a region of lung volume versus time that is gentle on both parts of the lung. Right here, using that colorful diagram, another way of representing the two causes of ventilator-induced lung injury: over distension here at high volumes and opening and closing injury at low lung volumes. Mechanical ventilation is critical for survival of many patients with ARDS. Without it, they become hypoxemic, and they can't, and then hypercarbic, and then they die. With ventilation, we can sustain gas exchange for hours and days while we work on the inflammation and the infections. But mechanical ventilation can cause lung injury, and it may prevent recovery. So one clinical trial that was completed in 1999 is represented here. Mechanical ventilation with low lung volumes designed to prevent ventilator-induced lung injury from overdistension. That clinical trial published here in the year 2000 by the ARDS network. Here you see tidal volumes versus time. These are in milliliters per kilogram of predicted body weight being a body weight based on gender, sex, and height. In the United States, predicted body weight is about 20% lower than measured body weight. So measured body weight would be approximately at 10 milliliters per kilogram a year, or 5 milliliters per kilogram if a patient was randomized to the lower tidal volume group. Mortality was substantially greater in patients who received the lower tidal volume. And because of this, the lower tidal volume approach has become the centerpiece of our ventilator strategy. Tidal volume goal is 6 milliliters per kilogram predicted body weight. We measure plateau pressures, the pressure in the airways when a breath of air is delivered and held in for half a second or a second. If the plateau pressure exceeds 30, we reduce the tidal volume further if it's being tolerated. Some people have used these rules to say, well, we don't really need to reduce tidal volume to get to 6 milliliters per kilogram. If the plateau is below 30, then we don't have to decrease tidal volume to 8, 7, or 6. Or let's use pressure control with an inspiratory pressure less than 30. So this interpretation would mean we would not necessarily follow these rules that came out of that clinical trial. Is there a plateau pressure below which there is no benefit from reducing tidal volume or inspiratory pressure? Plateau pressure, just to be sure we're on the same page, is the pressure that we measure in the airway opening with a half second or a second pause. Right? And the driving pressure is the difference between plateau pressure and PEEP. But we're focusing on plateau pressure for now. These data are taken from that ARDS network tidal volume trial. Shown on the horizontal axis are the plateau pressures measured on day 1 after randomization. And on the vertical axis is the mortality rate. Excuse me. If a plateau pressure of 30 was a safe limit, then we expect to see this graph plateau pressure to plateau here. But instead, plateau pressure, the mortality rate continues to decrease to lower and lower plateau pressures. So these data do not support the idea that we should modify the rules that came out of that clinical trial. And we reject that interpretation. Excuse me. We stick with this recommendation. Tidal volume goal of 6. And if the plateau pressure exceeds 30, decrease to 5 or 4. After completing the tidal volume trial, ARDS network turned to a different problem, namely ventilator-induced lung injury from opening and closing. Everybody got randomized to 6 milliliters per kilogram tidal volume, but half of the patients received a higher PEEP and half received lower PEEP. This is the approach we use to set PEEP at what we call the lower PEEP settings. For example, a patient might receive 50% oxygen and 8 of PEEP, or 70% oxygen and 10 of PEEP. This table was developed as a consensus in 1995 among the ARDS network investigators of how they use PEEP and FiO2 for usual care. If a patient was randomized to higher PEEP, then they utilized this higher PEEP and lower FiO2 approach. For example, a patient might be on PEEP of 12 and 30%, 16 and 40%. Here are the PEEP levels in that clinical trial. Higher PEEP and lower PEEP over 7 days, the difference on average of about 5 centimeters of water. There was no difference in mortality in this clinical trial. The mortality rates were, excuse me, sorry. As you see here, mortality rates in the 25-27% range. This was one of 4 large clinical trials of higher versus lower PEEP. Results of those 4 clinical trials are now listed here in this table of higher versus lower PEEP strategies. None of the clinical trials resulted in improved mortality. One of them actually resulted in a significantly greater mortality in patients who received higher PEEP, the so-called ARDS trial that used aggressive recruitment maneuvers and high PEEP. So why didn't higher PEEP work? Well, as I mentioned earlier, everything we do in clinical care, whether it be an aspirin to prevent a heart attack or higher PEEP to reduce ventilator-induced lung injury, it comes at a price. Sometimes the price we pay is worth it, and sometimes it isn't. Another thought is that effects of PEEP are variable and between patients. Some patients, like this one shown here, ZEEP is 0 end expiratory pressure, lots of atelectasis here in the dorsal regions. Raise PEEP in this patient, you get over-distension here, but very little opening of new alveoli, very little recruitment. In contrast, in some patients, you raise PEEP and the lungs open up beautifully. Lung compliance improves, arterial oxygenation goes up. So maybe we should try to identify the patients who are recruitable and randomize patients randomize patients who are recruitable to higher or lower PEEP. Maybe that way we'll be able to demonstrate an improved clinical outcome from higher PEEP. All right, so I'll try to get through the next several slides quickly to save some time. The rationale for extracorporeal membrane oxygenation in ARDS. With ECMO, we can improve arterial oxygenation and carbon dioxide removal. We buy treatment. We can ventilate the lungs more gently, promote healing. There's a strong rationale for this. Buy time for treatment and healing. But there were many disappointing previous randomized trials. On the other hand, the technology is improving. There's substantial experience at some centers. And usually when you do something repeatedly, you get better at it. And there are some encouraging, uncontrolled recent experiences at some centers. On the other hand, there are serious downsides of ECMO. It is very resource intensive and expensive. It requires almost everybody to be anticoagulated, and that results in bleeding, GI bleeding, cannula site bleeding, CNS bleeding, more transfusions, which can contribute to ARDS, infections at the cannula sites, limb ischemia, right ventricular perforation. So it's a good idea, it makes a lot of sense, but we pay a high price. I think this is among the various clinical trials of ECMO in ARDS, this is probably the strongest evidence for it, but I'm going to argue that the evidence is not very strong. Patients were randomized into this clinical trial according to these criteria. If the P to F ratio was below 50 for 3 hours, they could be enrolled. If it was below 80 for more than 6 hours, they could be enrolled. And some patients were enrolled on the basis of hypercarbic acidosis. Here are the mortality rates in that clinical trial. Mortality at 60 days, 35% in the ECMO group, 46% in the control group, a trend favoring ECMO, but not statistically significant. Is that enough to start using ECMO? Well, we usually require more evidence than this. And keep in mind, this is an open label trial. Everybody knows who is getting ECMO. And the trial was conducted by patients, by physicians who believed in it. Right? They had a key secondary endpoint, which was treatment failure at 60 days. The difference in the treatment failure was you either a patient died or they crossed over. As you can see, the ECMO group has a better treatment failure rate than the control group. But the control group would have a treatment failure if they died or they crossed over. But in the ECMO group, nobody would cross over. So it was only death. Doesn't seem fair, does it? The editorialist to this clinical trial wrote, "This clearly represents a bias against the control group. It makes it difficult to draw definitive conclusions regarding the usefulness of ECMO." I'm taking a step back from the ECMO trials to remind us that there were many ideas for improving clinical outcomes from various conditions in critical care. Flecainide was thought to be a way to improve mortality from patients after an MI with PVCs. Surfactant was thought to improve outcomes in ARDS. None of these ideas worked out when they were subjected to clinical trials. So we should be careful. Here's a summary of what I've said. ARDS is an important healthcare problem. Many medications intended to reduce outcomes did not work, with the exception, I think, of steroids in COVID-19 and perhaps in other causes of ARDS. Progress has been made primarily by improving clinical outcomes, by improving processes of care, mechanical ventilation, prone positioning, bloodstream infections, and so on. Thank you very much for your attention. If my voice holds up, I'll try to answer a few questions. In any case, there's my email address. Feel free to email me. Ask me about our prone positioning protocol. I'll send you a copy of that. Thank you very much.